Hello everyone, today we are operating on a middle-aged female with Schatzker Type III lateral tibial plateau pure depression fracture. While initial X-ray can sometimes be deceptive, the diagnosis was confirmed by a CT scan, which clearly demonstrates a significant depression of articular surface requiring elevation. The patient is positioned supine with thigh tourniquet inflated. We begin by marking our key anatomical landmarks, the tibial tuberosity, Gordy's tubercle, and lateral joint line. For a standard anterolateral approach to proximal tibia, the incision run directly lateral, at and above the joint lines, that curves through Gordy's tubercle and continues longitudinally down parallel to and 1 cm lateral to the anterior tibial crest. However, since this is a pure depression fracture that we plan to reduce and fix using a raft screw only, we are utilizing a modified limited approach, focusing inferior to the joint line that goes through Gordy's tubercle and expose the lateral proximal tibial metaphysis. After incising the skin and subcutaneous tissue, we open the deep fascia by splitting iliotibial tract down to Gordy's tubercle along the line of skin incision. The IT band is then elevated as a full thickness cuff both anteriorly and posteriorly using sharp dissection. Next, using a periosteum elevator, we carefully release the anterior compartment musculature from the lateral aspect of proximal tibia to expose the metaphyseal cortex. To achieve reduction without arthrotomy, we create a cortical window in lateral plateau metaphysis using a 4 mm drill bit. A bone tamp is then introduced through the window to gently elevate the depressed articular fragment from below. We continuously monitor and confirm the accurate anatomical reduction under C-arm fluoroscopy. Once satisfactory reduction is achieved, a provisional guide wire is passed subchondrally. This holds the elevated articular surface in place and guide our drill bit for cannulated cancellous screw placement. A 6.5 mm partially threaded CCS is then inserted under a sequential imaging, effectively rafting and supporting the articular reduction. To provide additional biomechanical stability, a second guide wire is passed subchondrally. After confirming parallel and accurate placement on C-arm, a second 6.5 mm cannulated cancellous screw of appropriate length is inserted parallel to the first. Final fluoroscopic imaging is performed to confirm the maintenance of our reduction and optimal screw pulses. Because we did not open the joint capsule directly, the traumatic hemarthrosis is safely decompressed and drained out using wide-bore hypodermic needle inserted inferior to the patella. Following a thorough irrigation and wash, we suture the incised IT band securely, followed by standard subcutaneous and skin closure. As you can see in the post-operative image, we achieved an excellent satisfactory reduction and rigid fixation. Thank you for watching and see you all in next video.